Good afternoon, good morning, good evening from anywhere in the world you are joining us. We are so glad that you are able to join us in the second webinar series on our ongoing conversation around how we, as individuals, organizations, can work towards shifting and sharing power towards advancing equity in population health. For many of us who were able to join the first webinar series, we had begun this conversation speaking on the historical legacies that have impacted on population health and the global health dynamics in general. Before I proceed, I would like to introduce myself. My name is Goodness Ogei Ode. I am from Nigeria. In sharing my positionality, I would say that I was born in a low-income family, a humble background, and being from Nigeria as a country, we also have colonial legacies because the British colonized Nigeria. And that in many respects shaped the kind of policies and structures we had, including the kind of reproductive health infrastructure that many women and girls like my mother and myself are able to access. This has also been directly or indirectly affiliated to how engagement on different frontiers in the public health sector and population health has also shaped me, and how I got involved in the sexual reproductive health and right advocacy. I have seen how in many of the spaces where I have worked, most of the priorities of the communities are not put at the fore because of the power dynamics on who is setting the agenda, what are they bringing to the table, and how equity is perceived. This has been pivotal to the engagement I'm currently on with the International Conference on Family Planning Power Shifting Subcommittee as a co-chair, and how we have also been able to broaden the work by also collaborating to have a committee of practice on shifting power in sexual reproductive health and rights, with the WHO IBP network, which I also co-chair. At present, I'm doing my master's in health policy planning and finance at the London School of Hygiene and Tropical Medicine and the London School of Economics and Political Science. Learning in these institutions and also looking back to the colonial legacies of how these institutions have were created, the knowledge that is being shared, and my identity as a young woman, as an African, and as a Nigerian is critical to understanding the disparities and inequities that shapes population health and in general the well-being of people. So I would say this reflects my passions and what I'm currently doing. Before I proceed, I'm going to give room for my co-moderator who is with me to also introduce herself. Let's welcome Onikeke Owolabi. Thank you.
Thank you very much for the warm welcome, Goodness. Hi, everyone. Thank you for being here today. Like Goodness said, my name is Onikeke Owolabi. Like Goodness, I am Nigerian and I was born and spent most of my life in Nigeria. I consider myself to be firmly middle class. I grew up in a lower middle class household. I do, however, acknowledge my privilege in having come from a very highly educated family. My mother was a physician, and so I grew up with her owning a private hospital. Like Goodness also said, Nigeria is a colonial country, and so the schools I have attended in Nigeria have shaped my experience of reproductive health and the information I had early on in life. A lot of this was mitigated by my privilege in having a physician and very liberal feminist parent. However, I grew up at the intersection of significant wealth and significant poverty. My early relationship with the health system, particularly with the state health system and government agencies, gave me critical insight into how our colonial past shaped our governance, our laws, and our administrative procedures, including the bureaucracy we experience. and the withdrawal of the British system and the eventual decay of the Nigerian economy shaped our health financing as it is today. This is what largely influenced my interest in both health systems and reproductive health. And I currently work as the Director for International Research at the Guttmacher Institute. I have no disabilities, and I have been very privileged on account of my background and where I'm from to have had a scholarship to study at some schools in the UK, where I've also had to grapple with the colonial perspectives and their background on tropical medicine and international health in non-middle income countries. It's my pleasure to be here today, and I know we have a fabulous panel lined up. I look forward to engaging with them and with you, and to talking more about how we can shift power and advance equity within population health research in our work. Over to you, Goodness.
Great, thank you so much. I'm excited to do this with my Nigerian sister. But trust me, we have a very diverse group of presenters who will be sharing the work they have been doing, shaping more equitable practices in population health from different parts of the world. So maybe this is the last Nigerians you may be speaking with for the rest of the webinars. So as a way of getting to know you all better, we would like to run a quick poll just for you to describe yourself. And just in one word, how would you describe your professional role? Feel free to use 2 words if it's more than one word that describes you. And while you are at that, I want to encourage us to check out the first webinar series where we spoke on the legacies or how colonization has impacted on population health. So what are the colonial legacies? How has history impacted on population health? What are the power dynamics and what are the present trends? We had really inspiring Dr. Zenza Menzio, and you can find that on the International Conference Family Planning YouTube page or the ICFP web. Feel free to check that out. I also know that the IAPHS website, and it was very informative. I want to believe that many of us has taken the poll, and we are glad to know you better. Moving on, we have a quick brain teaser to get you involved into this conversation. We had this in the last session for those of you who are joining us for the second time. We want to get to also engage you to understand your perspective on today's topic. As much as today we'll be looking again, understand what do you think is power? My colleague will be sharing that on the Jamboard. So just feel free to put in your thoughts. What is power? If you can share that with us, I would be looking out for your response as soon as you're able to get access into the Jamboard. If you have not gotten into the Jamboard link, just check the chat box. You would find the link to access the Jamboard. I can see that someone is saying autonomy, and I absolutely agree with you. Core to power is autonomy. We have seats at the table. Very correct. Very correct. Thank you. What is power? Privilege. Often money, very true. So I often tell people that he who pays the piper dictates the tune. And we see that in many philanthropic engagement or aid engagement. Influence, privilege. Okay, this is interesting. Access. Some people also have like very interesting points on it being self-driven rights based on decision making for self and community. Why it's interesting. Access, knowledge and information. So these are really amazing response, and we appreciate you. We're going to move to another interesting question to say, now you have defined what is power in your own perspective. Who has this power? So we'd love to get your thoughts on who has the power. Still on the Jamboard, can you just respond? Who has it? So who has this power? I can see that we've seen response of donors. I can see another saying, white people with money. Okay. Who has the power? Or who has power? Okay, white people with money, the Congress, in a country with the elites, people with money. Money is really coming out strongly. Still countries who colonize. So I remember in one of my seminar discussion in school on one of my courses on health policy, process, and power, a group defined the colonizers and the colonized. So I see this point resonating with still countries who colonize, so maybe decolonizers. There's also an interesting one on politicians. In many instances, we see how that happens. Okay, they're calling out the Gates Institute, so I can see Gates. So I'm not sure if this is Gates as an organization or Gates as people who are the gatekeepers. I'm not sure, but yeah. Then we see white people, colonial countries, on your personal experience or the work you have done, and your perspectives are valid. Thank you for sharing. Okay, thank you for clarifying. I believe the person has clarified to say gatekeepers. Thank you. So we see white supremacists, capitalists, patriarchy, and yeah. So one last question. One last question. Now we've been able to say who has it. How does this power impact the work that you do? How has it shaped or made or mad or challenged you? How has this power impact work? Thank
Yeah, there are lots of good comments coming in. We see funding barriers. How someone said, I cannot think of the way it does not impact my work, which I think is broadly true. Oh goodness, you're back. You want to keep going? Not all perspectives are heard and incorporated, and it's incomplete. Lacking community-powered and driven solutions. Power determines what
Thank you
topics get
so much
funded.
for taking just filling for me.
Yeah, power creates funding barriers. Research focusing on the wrong questions or determining whose questions get asked. The priorities of people with money and power are often prioritized. Yes, yeah, considered more important. Goodness, I'll pass it back to you.
Yeah, so thank you so much for your feedback. And with that, we would move excellently and beautifully into getting to understand some of the ways individuals, organization, and partnerships are facilitating the equity we would love to see in population health. And this session will be handled by my co-moderator, Oni. Over to you, Oni. Thank you.
Thanks, Goodness. So I'm very excited to introduce a stellar panel to you today. I'm going to ask them to introduce themselves really quickly in 1 minute. I want them to tell you their names, what organization they represent, and their role, and to sort of say a little bit about their positionality, so who they are and where they're coming from. And then I will pose an open question to them. Just to make sure we can go in an orderly manner, let's start with Nandita. And 1 minute.
Yeah. Wonderful. Thank you. Thank you for inviting me to be part of this session. I'm delighted to be here. My name is Nandita Tate. I am a technical officer at the WHO, where I lead the Implementing Best Practices, or IBP network, which is a network of civil society organizations working on family planning and sexual and reproductive health and rights. Before that, I was for 10 years with USAID, which is a big donor agency based in the United States. And I was based in Washington. I was really moved by the positionality question and what we heard from both you, Oni, and Goodness. And just a quick background, I'm Indian Canadian, but I spent my schooling in North America, Canada, and the US. I would say I'm from a very privileged background in many ways, access to higher education, middle class, opportunities to work in global health at USAID and WHO. At the same time, I feel like my heritage has given me kind of an interesting and sometimes conflicted experience. In my master's research, I remember being able to go into rural areas in India, talk with women really directly about birthing practices. And the reason was because I looked like them. And that was very clear to me from the start, which is why I was able to get this position. They needed somebody to go into these communities, and they needed someone who looked like the people. On the other hand, I've been in countless meetings in Washington or Geneva, sitting around tables with people from North America, or men, women, generally European descent, talking about how women should give birth, how they should be using contraception. And almost always these women that they're talking about are from Asia or Africa. So they're brown or Black women. Many of them from South Asia also look like me. So it's been a very conflicting experience for me working in this sector increasingly. But I've tried to sort of use my position as lead of the IBP network to really create networks and create spaces. And that's sort of what I see my role as. I can't speak to an Indian woman's experience in India, but what I can speak to is my own experience, and I can create spaces for others to share their experiences. And that's what I aim to do through the IBP network. Thanks.
Thank you so much, Nandita. On to you now, Innocent.
Thank you so much. Hi, everyone. As you introduced me, my name is Innocent Grant. I work with a youth-led organization based in Tanzania called Young and Alive Initiative. I work on the programs department, and I'm also part of the IBP network that Nandita just introduced it as part of the leadership, co-chairing the IBP network from Tanzania. And yes, I'm so much looking forward to this conversation today. I think it really matters. And for me, I don't know where to start sharing about my experience, but I think I started working in the field when I was just a student doing clinical medicine studies in the southern coast of Tanzania, a place called Mtwara. And we just started as a student-led sexual health club within the college. And what motivated us was stories of the clients we met in the hospital. That motivated us to keep doing not just studies, but doing something more, enriching communities with right information related to their health. And that motivated me to work and keep doing the work that I'm doing till today. And I think I'm so much looking forward to share some of the possible pathways when we're talking about power shifting, especially with experience working with Mandita, also with the experience of the activities that we've been doing recently in Tanzania in acknowledging communities' power in changing their own communities, transforming their own communities for better reproductive health outcomes. So I'm so much looking forward. Many thanks.
Thank you so much, Innocent. I'll pass it on to Amber.
Hi everyone, thank you. Yeah, my name is Amber Clark. I work at the London School of Hygiene and Tropical Medicine with the FAIR network. So that is the Fight Against Institutional Racism network, which we're going to tell you all about. But I am the advisor and coordinator of that network at the moment. I'm between LSHTM and I also work for the UK's Department of Health and Social Care as a health improvement and disparities researcher. My background in terms of work, I did my MSc at LSHTM in 2017-18, worked in the development industry for a few years before coming back and doing a postgraduate diploma in post-colonial studies and critical development studies. So I try to bring those perspectives into the work that I do now with the FAIR network. In terms of my positionality, I would first say that I'm a Londoner. That's a key identity for me, born and bred Londoner. I'm a woman, my pronouns are she, her. In terms of ethnicity, when I do the census, I do tick the white British box, but at the same time, my heritage is Jewish on one side and Irish on the other, which, yeah, reflecting on positionality is definitely a very interesting question. And I'm realizing very much in the current moment in climate that a lot of my activist spirit comes from that history of essentially freedom fighters on both sides as well. So I'll stop there. But yeah, really, really looking forward to this conversation and hearing about how other groups are trying to do the same work that we are at LSHTM.
Thanks, Amber. On to you now, Sally.
Thank you so much. I'm Sally Hafiz, and I'm also part of the FAIR network, working with Amber and colleagues to foster and fight institutional racism at LSHTM. My background, I've been working in public health and humanitarian crises for the last 10 years with the Red Cross and also UN agencies. My positionality, I'm North African woman from Egypt, which have been colonized as well by both the French and also the English, which leaves a long colonial history in Egypt. But I also been navigating a very colonial spaces, particularly the humanitarian sector, which have been full of white saviorism. And I very commonly attended meetings where I didn't look like what a humanitarian should look like. So yeah, that made me more interested to kind of unpack these dimensions more and examine them more. Yeah, thank you.
Thank you so much for sharing. And like we all said, it's always a very, it's always a great thing to sort of reflect on who we are, where we're coming from, and how we move and live in multiple spaces and places, and what our backgrounds allow us to do, and also what they limit us from doing effortlessly. So I'm going to pose a question to our fabulous panelists today, and I want them to share their experiences, their best practices, and then we will invite the audience to ask questions and share with us their thoughts on what we have discussed.
ICFP, can I interrupt you?
Yes, please.
I'm so sorry. I think, did you forget to introduce Patrick?
Iraq. Oh, yes, I am so sorry. So, Patrick, could you please introduce yourself? Thank you very much, Amber.
Hello, everyone. Thank you very much. I'm Iradukundagat Patrick. I'm living in Rwanda. It's a country which also has been colonized, as you mentioned, with Nigeria and Egypt. And apart from that, it's a country which has faced a genocide against Tutsi in 1994, which is the sad story of the country. But also it's a country which have a resilience and which is building faster to recover from that. and setting example as a fast economically growing country. So I have a background in biomedical laboratory sciences, and I have been doing clinical trial at the London School of Hygiene and Tropical Medicine. I'm a researcher who have made 13 publications so far, and currently I'm working at Rwanda Food and Drug Authority, where I'm a pharmaceutical regulatory specialist. And what I could add is I'm a member of the FAIR network at London School of Hygiene and Tropical Medicine, and collaborating with Amber and Sal and the team whom we are representing here. We are all looking forward to learning from all of you on how you are doing and the best practices, and to share our concept and what have been done so far. Thank you.
Thank you so very much, Patrick, and my apologies again. We do have one more panelist who we're going to try to pull in, but I'm going to pose my question, and then I'm going to invite our panel to provide responses. And if we're able to pull in Laura, then I'll ask them to introduce themselves. Oh, perfect. I think Laura is here right now. Hi, Laura.
Hi, everyone. Thanks for all of those introductions, getting to know you all. It's really nice. To talk a little bit about my background and my research. So I'm a medical anthropologist who completed their PhD at the University of Kent in the UK. I'm white, British, and Irish. I have both nationalities, and I grew up in the north of England in the Irish diaspora. My sort of upbringing involved going to Catholic school and being surrounded by a lot of campaigns to stop teenage pregnancy during the crises that was in the 2000s in the UK. And it's more recently that I've started to think how that might have affected my interest in reproductive justice. I've also experienced endometriosis, and that's something that I always sort of take into my understanding when I'm looking at reproductive health. The different ways, the different sorts of diagnoses and conditions that are not always given much attention comparatively to other issues we talk about in reproductive health or population health. And yeah, I mean, I think from a young age, I've always been interested in movements for self-determination, freedom, social justice, and health inequalities. And all of these things sort of combine to lead me to do my doctoral research and now postdoctoral research looking at epistemic injustice and reproductive justice in the global south, particularly in Timor-Leste, where I carried out extensive fieldwork, and now in Nepal and the Philippines with my co-teams there.
Thank you so much, Laura. So I'm going to ask one question, and I'm going to give each of the panelists 5 minutes to respond to that question. I will unmute at 5 minutes. You will see my microphone open up, and then I'll let you talk for 1 more minute. So that's how we're going to do the time check. I'm not going to cut anyone off. So my question to you all is, what are some of the dynamics we need to consider along the population health continuum when approaching power shifting? And some of the things I hope you will talk about, especially the ones you have the most experience with, so you don't have to get through all of them, include who sets priorities and funds who, how is data gathered, stored, and analyzed, who decides on the validity of the data and what methods of data collection are most appropriate, who uses the data, and who actually benefits from using the data. I'd like us to start with Nandita and Innocent, then we'll move to our colleagues from the FAIR network at the London School, and then Laura will wrap it up. So Nandita and Innocent, over to you.
Super. Thank you so much. So it's a great question, and there's a lot of directions I could go with this question, and I've given it a lot of thought. But I wanted to just share an experience first quickly about setting priorities. We were working with a partner a couple of years ago who had some funding from a donor to improve quality of care in maternity hospitals, maternity clinics overseas. And they wanted to do some research on creating a supervisory checklist for nurses to make sure that quality could be improved. So they came in, from North America, we won't say where, and had their checklist and sort of started getting the teams on the ground ready to sort of start the study. And in our role, I was particularly interested about working with local partners, and I was seeing some of the nursing staff and some of the nursing associations locally kind of just not speaking up. And so I asked one of them, well, what do you think about this? And she said, you know what? She said, I don't need a checklist. If you want to improve quality of care here, buy me a washing machine for this clinic. Because after I deliver babies, I spend my time hand washing the sheets. And then another woman chipped in and said, yeah, and we've also run out of, commodities. And so there were all these other priorities, but the washing machine really got to me. And I went back to my colleagues at USAID and I said, well, why do we need this checklist? And why don't just get washing machines? And the answer I got back was, well, washing machines aren't sustainable. Washing machines don't build capacity. And we are funding partners to provide technical assistance. And a washing machine doesn't provide technical assistance. I mean, how many of you have heard those terms thrown around all the time? So it's just an example about when we're thinking about priority setting, partners on the ground, local partners, they know what they need. People know what they need. They know what the priorities are. And they often voice that too. It's just a matter of listening. And I find that oftentimes, unless we actually meaningfully shift power, we're not really listening. So I just thought that was an interesting story that has really helped center me in terms of this work. But I wanted to just mention 3 things that we've done as a network. WHO, as you know, is a member state-driven organization focused on setting norms and standards, global guidelines, et cetera. But one of the things that they've invested in 20 years ago was this network of civil society partners called the IBP network. And at the start, it was governed by a steering committee that was largely the international INGOs, IPPF, FHI 360, others. And it was a great network. The idea 20 years ago was, could we create a platform where partners could exchange information, avoid duplication, et cetera? And those partners sort of stayed the same for 20 years or so, a little under 20 years. When I joined about 6 years ago, I felt like while those partners are very valuable and still are, there was so much interesting work going on by local NGOs or civil society groups. And so we really tried to welcome more of those partners into the network. And we grew, and over 50% of our members' organizations now are local partners. But that wasn't enough to really shift the power. And so what we did was we restructured our governing board. And that's really where we saw a difference, because that was the board that was making the leadership decisions. And that's what Innocent was talking about. Our steering committee is now co-chaired by the Young and Alive Initiative based in Tanzania. And members of the steering committee really reflect a range of local partners. And we've really seen that shift influence the kinds of work that we're doing, supporting more local partners, setting up communities of practice on power shifting, for example, making sure that we have interpretation into multiple languages for a lot of our events. So I think that institutional shift is really critical. The second thing I'll say is direct funding. And we, of course, are not a funding agency, but we do try to provide support to our members as much as we can. And we've been increasingly trying to do it in a way that really trusts them to do it. And I think that's something that donors often forget, that, trust is such a big part of what makes intervention and investment successful. And so we've been trying to fund activities from our partners who we know do amazing work. And we've had a great experience with the Young and Alive Initiative, with AFIDEP, and some other groups as well. And then the last thing I'll say, I know I'm at my 5 minutes, is just trying to think about how we build capacity in a meaningful way. We've been doing a lot of work on how do we better document implementation of reproductive health interventions. And what we've learned is that the traditional ways of documenting peer review publications, for example, just aren't always resonating with partners, especially local partners. We've been doing a lot of storytelling and kind of using different means. But what's critical here is we're building that capacity in a meaningful way. So for example, we launched a storytelling initiative and asked people to submit their stories, but we paid people. We offered a stipend because it takes effort to go out to your communities, write a story. We're working on some interesting research and tapped some young researchers to help with a systematic review, but we're paying them a stipend. It's not only that they're going to get great experience working with WHO, but they're getting some kind of compensation. And then the last thing I'll say, again, speaking to sort of our positionality, is don't be afraid to bring your personal experience to this conversation. And I've struggled with that at WHO, where we're a science organization, the need to be objective, but I have found that it can be really valuable. And I've published about this, my own personal experience with discrimination at the facility, complicated, traumatic childbirth, all of that stuff has actually made me a stronger advocate and a stronger scientist. And so I encourage us to think about that as we're doing this work, not only in how we prioritize the work, but think about that when we're hiring people. You know, maybe the person with the PhD isn't the best candidate. Maybe the person who actually lived through or grew up in a camp actually is better suited to do this work. So I'll stop there, but thank you so much again for this opportunity. Thanks.
Thank you so much, Nandita and Innocent. I absolutely loved the first story and how you wrapped it up. And it's true. I feel like one of the things people don't realize is the person who has the greatest power of privilege is often the one who withholds trust. Trust in people understanding what they need, trusting people who have lived through experiences but might not have formal qualifications to do the job. And like you said, trusting people to lead and trusting people to be able to do the right thing with money. Privilege often comes with lots of boundaries around what you want people to do and how you're going to monitor them. It's very paternalistic, and it's very important that we recognize that. So thank you both. And I personally have seen the evolution of IBP since you started appearing in my inbox, and it's absolutely lovely to hear about that firsthand. I'll pass it on to our fair colleagues now. Like I said, I will unmute at 5 minutes. I'm not going to rush you. I'm just trying to make a little bit of time for us to talk to the audience and talk back to each other. So Amber, Sally, and Patrick, over to you.
Thank you so much. I can just quickly introduce the slides. Hold on. Yeah, you can see my screen, yeah? Yeah. So we're just going to speak about a couple of different things, maybe not exactly answering, as you say, all of those questions about who owns the data, who benefits, but our work definitely encompasses that. So we'll touch on quite a lot. We'll keep the time in mind. We'll definitely try not to go over. Just to very briefly give the outline, we're going to speak about our very unusual network model. We think it's an interesting one to hear about. We'll speak about a recent decolonizing charter project, so that will speak a bit more concretely to some of the questions that you posed about equity and epistemic justice in this work. And then also we want to speak a little bit about advocacy and activism and our attempt to shift power specifically using those types of methods. So I'm going to pass over to Patrick to speak about the FAIR network model. And Patrick, if you just let me know when you want me to change the slide, I can do that. Patrick, I think you're on mute. Yeah.
Yeah, thank you. So thank you, Amber, and thank you for the previous presentation, the previous response from Tate, who has provided a good idea on how to approach this with trust. And I believe that as we go through this slide, we will see that with the organization like RSHTM has given trust a fair network to do something about fighting for racism and so on, so that it's the basis foundation. So could you go to the following slide? So about the FAIR network, it is an independent network within RSHTM and facilitate dialogues and actions around issues of racism and colonial legacy in global public health education, research and practice at RSTM. So this is around the main role of the FAIR network. Next slide. It started in 2020, where there was a revolution of Black Lives Matter. I think most have heard of the scenario, and it started functioning as a grassroots activism group of the RSTM staff, student, and alumni, but not part of the institution. It was later incorporated into the institution following an external investigation into a case brought to senior leadership by the activism group. And then we worked with the senior leadership to agree on the model of FAIR network. Next slide. So among the key functions that the model had to do was to provide a discursive space for students and staff where individuals can raise issues relating to racial injustice and the coloniality that arise within the institution, and it produce and distribute the knowledge in service of racial justice and activism. From the issue of knowledge sharing, it prepares different webinar, and it has a blog and social platform that are used to provide different knowledge and provide the advocacy and accountability. It's an advocate and accountable group focusing on reform and progress in institutional policy and the practice. From this point, maybe what can interest you is the work that has been done by this network, where it was about decolonizing the curriculum, and from there the network contributed to decolonizing the curriculum. Could you go to the next slide? About how the model works, I'm going to invite Sari to continue and provide more details so that we could share. Thank you.
Actually, I think Amber is better suited to talk to the model, and I will join and provide more input on the HHCC experience.
Sure.
Okay.
So thanks, Ali. I'll just very quickly touch on this because there's too much to describe in this short time. But essentially, we have this agreement with the institution whereby we're an independent group. We're independent of the institution, but we are part of the institution, though we have free speech, and our free speech is protected and valued. So that took a long time to come up with that statement of intent and agree it with the school, but we have a shared vision, objectives, and ways of working, which allows everything to run fairly smoothly. We have an agreed funding model, so all of our projects can be properly agreed, signed off, commissioned. We have an internal email address, but an external website and anonymous blog. And we will talk about why that has been important in a minute. We have a core steering committee of about 15 people from across the LSHTM community. We have a coordinator, who is me at the moment, who is paid by the institution, but who is answerable to the steering committee. And we are a network without membership. So it's not something people can sign up to per se. It's something that we say, you know, everyone who's involved in this work and comes in and out of it and adopts this agenda and supports this work is part of this network. So there's more than 1,000 people on the WhatsApp groups and mailing lists, and we work with many, many individuals across the centre on different projects. So Sally, I can hand over to you to talk about one of those projects.
Thank you so much, Amber. Indeed, we have been trying to collaborate with multiple centers and groups at the school so we can test with them different ideas and to build more public commitment in terms of decolonizing the work that we do at the school. So we built a new partnership with the Humanitarian Health and Conflict Center at LSHTM so we can establish a charter. I think, to our knowledge, it's the first of its kind to be done and used in a research institution that would guide and set the scene and the roadmap for changing and shifting the power in the way we conduct research partnership, but also teach at the school. Next, please. So our work basically started by, as a research institution, started by collecting evidence. So we conducted 2 pieces of research, including literature review to understand what are the existing good practices in terms of decoloniality and what has been successful, what worked and what didn't work, but also engage a little bit deeper with the ideas and thought what decoloniality in a research institution and in global health and humanitarian context particularly would look like. And we complemented that with a qualitative research with our students, with our staff, with our partners from organizations that the center have been partnering with in conflict-affected countries, so we can understand also their experience and what have been working well, what are the practices that we need to invest and propagate more, and what are the things that we definitely need to address and challenge more. Next, please. And from the research, we decided to co-design with the members of the center a charter. This charter basically contains 3 core principles and 4 commitments based on the findings of the research and with direct input from the center members, including the first core principle is to approaching decolonization as a comprehensive practice, not just a one-time exercise that we do once a year to enhance how we look as an institution, but it's an ongoing and comprehensive practice that we cannot just take out of the larger understanding and larger context. The second principle basically is based on disruption of racialized power dynamics inside the institution, but also in relation between the institution and external actors, including donors and also our partners that we work with. And the third principle is basically to understanding change as a continuous process. And I think that something came very strongly from the research that we conducted, that some people perceived decoloniality and decolonization as like a one-time exercise. And by developing the charter, we already decolonized the institution, which is not how we saw it. We saw this as a process, as a continuous process. The charter and the implementation plan for the charter are step 1, and we see this as an ongoing process or journey that we should embark on together. And to do that, there are 4 commitments that the center and center members committed to.
Sally?
Yeah.
Thank you. Keep going,
okay.
But are you able to wrap up in 1 minute, please?
Yes, okay. So the commitment basically is to be led by those from crisis-affected countries, including organizations and also communities, to challenge some sort of neutrality of humanitarian practices and the same neutrality of public health, as well as a standalone or kind of people sitting outside the scene, not engaging with the consequences that's happening. Things in relation to risks and capacity and redistribution of resources. And to address that, next, please. To do that, it requires direct engagement with our internal work and business model, because this is obviously a model that we benefited from as an institution for a long time, a colonial model. So that requires us to revisit our business model and how we work, how we partner, how we conduct research. But in the same time, it requires us to engage directly with some of the structural barriers, such as how institutions and donors design their funding and design their funding agreement, and who owns the data, who owns the intellectual properties, and all of these issues. Things such as visa that came very strongly from students, and we still have to struggle with things relevant to epistemic justice and which narratives matter in the way we teach. They were all coming as part of that. Saying that, this process doesn't go without challenges. As exactly my colleagues mentioned, we kind of a friendly enemy, or I don't know what they call it, not friendly, yeah, critical friend.
Friend, there you go.
Yes, with the institution, and that's why there is some questions about the autonomy and where we stand in terms of working with this institution and collaboration with them. Same things in terms of implementation. How practical are the implementation plans that we developed and co-developed with the center members, with all the given structural constraints that are happening? Amber, I think over to you. Sorry, it took a little bit more time than planned.
No problem, no problem. There's much to say on that project. I'm going to try and just do a couple of minutes on power shifting, specifically our advocacy and activism, because it's one that's easier to just either forget about, leave to the side, or also be too cautious to talk about. But we are an advocacy and activism group still. We try to remain true to those more radical roots. And so we'll talk to you a little bit about some anti-colonial solidarity with Palestine. So I definitely understand this part of our work. Sorry, I have some notes on my other screen, so if you see me just flicking between the two. I understand this part of our work as something that remains more firmly rooted in radical anti-racist praxis and concrete decolonization, and perhaps resists more, as I think Sally maybe just touched on, how some of this work is, can be easily drawn into a more liberalized kind of version of a decolonial or anti-racist agenda. So that would be one that kind of sits more comfortably within an institution without really demanding any big change or structural change. But in terms of our anti-colonial solidarity with Palestine, I want to talk about some of the blog posts that we have published recently. So these are the ones that are on the screen here. Everyone Wants to Decolonize Until Palestine was the first one that we wrote a couple of weeks ago now. Ask LSHTM to abandon its neutrality on Israeli occupation, and LSHTM's censorship, of the truth about Palestine. So we use this anonymous blog as hosted on an external website as a real example of a more radical way that we try to shift power within the institution, or what we might call strategically inhabiting spaces for justice-oriented education and activism. So as I say, there are 3 examples there of some of the blog posts that we have published recently. So one highlights decolonization as concrete practice and asks specifically why this agenda, this decolonizing agenda, which so many institutions have signed up to in recent years, has basically been pushed aside in the context of Palestine, where really it should be absolutely at the fore. The second one in the middle there was an open letter to LSHTM leadership by the students of LSHTM, who wrote that letter, and we worked with them and shared a blog post about it for signature. And then the third is about the censoring of academic freedom of speech in the UK right now, specifically regarding Palestine and war crimes that are being experienced. So this kind of anti-colonial solidarity has really significant challenges within an institution such as LSHTM, circling really around censorship of academic freedom of speech. And when we are in that kind of moment, as we are in the UK, there are genuinely very important legal considerations around public profiles and misinformation that we really have to consider. So in terms of legal considerations, there is the potential for staff and students to be penalized for solidarity efforts with Palestine. And we have seen that happen in the UK in recent weeks, with professors being called to resign from posts and whole advisory boards being dismantled overnight because a member of that advisory board may have expressed specific solidarity with Palestine. And we saw that happen at UKRI just recently, which is a big example. So within this context, there are threats of legal action. There is public targeting of academics, and we have all seen this recently. There's also a big issue of misinformation and the result of censorship, which means that our academic communities and our student communities are feeling very unsure about engaging. And the way that we deal with that, just to mention briefly, given that those are very serious considerations, is we maintain really good relationships with LSHTM leadership. So we discuss all of our actions and activities before anything takes place, and that offers lots of protection and understanding and for things to run relatively smoothly. And in terms of misinformation, it's really about using our position to share knowledge and resources kind of via our channels. So then just to finish, our asks of LSHTM are quite concrete in this context. We're asking it to uphold its commitment to act with integrity, take a stand against these attacks on freedom of speech, encourage open dialogue, and very importantly, we don't have time to discuss further, but to reject the notion of neutrality in global public health and in humanitarian health crises. So as we have all kind of mentioned, this is how we try to shift power and advance equity at LSHTM. It's, yes, this thing of being a critical friend and obtaining a seat at that table, but it is also obtaining institutional resources through our funding model. It is creating a space to organize and mobilize, which works really well at LSHTM through FAIR as a platform, and bringing critical theory and critical perspectives into all of our work. I'll stop there. I hope we haven't gone too much over time. Thank you so much for the opportunity to share about that.
Thank you so much, Amber, Patrick, and the FAIR group. Like you said, power shifting doesn't happen in one day, and I think with some of the issues you've raised, it's a really nice way to segue into Laura's presentation. I'm also going to hand it over to Goodness. It's been lovely being with everyone here today, and I hope we all get to circle back so that Innocent can help wrap it up. And over to you now, Laura.
Okay, I just need screen sharing permissions, if that's okay. Thank you. Okay, and I'll just get started. 1 second. You can just bear with me. This doesn't seem to be working. Let me try again. Okay, well, I'll just start talking whilst I'm trying to get the slides up, but apologies for this. What I'm going to talk to you today is, there we go. Thank you. Power shifting and epistemic justice. So as an academic, I'm positioned within several institutions, several academic institutions, but my research from a medical anthropological perspective and approach is very much about trying to understand different power relations in regards to health, and particularly reproductive health, and also understanding, how we can make meaningful partnerships through research. So obviously, obvious criticisms of academic research is that so often it happens, in the ivory tower, so to speak. So how can we shift that and ensure that when research is done and when it's used to inform policy or inform decision making, it is much more representative. Next slide, please. So I'm going to talk very quickly about my work on reproductive justice in Timor-Leste, and then I'm going to move on to talk about a project which is a participatory action research project with partners in public health in universities in Nepal and the Philippines. So next slide, please. What ties these two projects together for me is this idea of epistemic justice or epistemic injustice. I guess the injustice part definitely comes from that dominance of a particular form of knowledge, and particularly in health, healthcare, and perhaps, broader than that, there's a quantitative and very sort of what we call naturalist or biomedical form of knowledge that exists that tends to silence other voices. Anthropology for a long time has been looking at different forms of knowledge, how knowledge is created, and who has the power to speak, and addressing those sorts of inequalities. So epistemic justice really is about decentering dominant quantitative and biomedical forms of knowledge for me in this research. Recognizing and making space for unheard voices also part of that, and looking for new ways of participation and collaboration to work with communities and individuals to co-construct knowledge, as opposed to it being something that's sort of parachuted in from elsewhere, or preached down to people, which is often the case. So I'll talk quickly now about the project on reproductive justice. If I could have the next slide, please. So reproductive justice after conflict in Timor-Leste was part of a doctoral project that I did, where I conducted about 2 years worth of research in Timor-Leste with communities that I lived nearby. This included healthcare clinics, radio stations, also included the local schools, different organizations, including religious organizations. And my goal was really to try and understand how life is being reproduced after conflict in Timor-Leste. Next slide, please. So Timor-Leste is in Southeast Asia. It is on the edge of, I guess, Southeast Asia and the Pacific. And I'm going to quickly give you a very brief overview of Timor's reproductive history. So it was a place that was affected by indirect and direct colonial rule and violence for a very long period of time. It only gained independence in 2000 after a referendum that was brokered by the UN. 2002 was when it officially became Timor-Leste or Timor-Leste, its national names. And contrasting the violence of the occupations by Portugal, by Japan, by Indonesia, this territory experienced a massive population boom after independence. So prior to independence, population growth was very small. It was affected massively by massacres and what came to be allegations of genocide, although it was never legally categorized genocide. And we had this massive population boom. So by the time I arrived in Timor-Leste to consider, what does reproduction look like in a newly independent nation? How do people repopulate after conflict? There was a very strong feeling that the population growth was causing a demographic danger in terms of rapid population growth, 70% of the population being under 30, not enough jobs, poor economic progress. And, this was sort of categorized as this is something that can potentially lead back to conflict. However, there was also the hopeful side that this demographic dividend could be capitalized on if only people would start having fewer children, get good jobs, and improve education. So these were sort of big asks for the government to do that. And it was very much an example of what I saw as this developmentality around shaping people's health and reproduction. If people will make the right choices, then, economically we'll all be more prosperous. And we have to do that collectively. So if I could have the next slide, please. Just to, give you an overview, that was a shot of the mountains, not particularly overpopulated. So using a reproductive justice lens to investigate this sort of phenomenon of how, Timor had gone from massive loss of life to being overpopulated in the general narratives, I took the reproductive justice framework, which many of you will be familiar with, drawing on Loretta Ross and Sister Song, and also work by Ricky Solinger, to look at, what would reproductive justice look like after conflict, after mass loss of life, in a newly independent country where the Catholic Church is very much embedded through Portuguese colonialism, and the country economically is reliant on its former occupier Indonesia as its biggest neighbor. Next slide, please. So these are some of the communities that I was working with, and I was trying to understand how reproduction perhaps was communicated through sharing of resources, but also sharing of ancestral places in the landscape, ancestral homes, connections between kin, but how part of that was not only about making sure that kin were connected and kin were abundant, but also that, you know, as a population, as a national population, Timor-Leste were able to replace people that they'd lost in the past. So narratives that you might have heard elsewhere after conflict or after genocide. Next slide, please. One of the things I've tried to do in my work, whilst partnering with local organizations in order to do this, but also making sure that the activists in my field site are very much part of the voice that gets portrayed, and making sure I bring those people to different events or different projects as ways to speak together. But the argument that came out of this thesis was very much from me, for, you know, a white person from the global north, was to say, we need different ways of trying to understand population. We can't continue to measure population in a very demographic sense, based on the science that was generated as part of a legacy of ways of control and colonization. The sort of knowledge that we have today about the way that economy and population work together tend to show or think that by controlling reproductive bodies, we control the economy. And that is something that I absolutely want to dispel, and also say that, you know, in Timor-Leste, we had this phenomenon of economists and demographers worried about population growth. At the same time, local people were worried about population abundance, but also family abundance of well-being and prosperity, which happens through a spiritual landscape, but also with more people in abundance, right? So life in abundance was what local people were seeking, contrary to sort of perhaps some of the development reports which sought to, you know, improve reproductive health. Great, absolutely fantastic, but improve reproductive health for the sake of the economy, as opposed to for people's general health and well-being. On demographers and people working in global health development areas to pay attention particularly to how people count themselves, and to pay attention to local knowledge around population narratives, around the environment, around sustainability, to call for a return of local knowledge to be involved in these sorts of strategic development plans. Next slide, please. So my argument is, you know, if reproductive justice matters, we must consider how reproduction is and has always been what Michelle Murphy calls distributed, that is, operates on many different levels rather than just the individual or the state level. And we also must consider how people count themselves, so that when we do come to population policy or health policy, and we're relying on statistics and demographic information, we are involving people's perspectives, understanding their experiences in how they are counted and want to count. What is their perception of their, you know, abundance or demographic danger, for example. So that was a piece of research on epistemic injustice, which led to, next slide, please. Me participating in this project at the University of Sussex. It's led by Anna Robson-Plant with co-Is in Nepal and in the Philippines, and it aims to empower communities through university partnerships in public health. So this project has three co-investigators. Next slide. Anna Robson-Plant at the University of Sussex, where I'm also working with her. It also has a team of 7 people in the Philippines, led by Trisha Bauster, and then also a co-investigatory team in Nepal, led by Kamal Devakota, at the Tribhuvan University in Kathmandu. So this project is very much a way of making sure that local knowledge and Indigenous knowledge is incorporated into particularly medical education. So education for doctors, nurses at a national level who often have to rely on textbooks or on curriculum developed for them by people from international institutions, particularly knowledge from the global north, a particular biomedical model. This project is aiming to bring local and Indigenous knowledge into those curriculums so that the university teams who are based there can co-construct knowledge with the community, and this will, enable both the community to receive better care, but also the medical students to have a much better understanding of the needs and issues in their locality, but also the different ways of knowing, the different epistemologies. I've got a terrible cold. Next slide, please. I'll wrap this up. So, as I said, empowering communities through university partnerships in public health looks to pilot a more democratic model of partnership in public health between medical institutions, so the medical schools, and local communities. Obviously, our challenge here with this project, which is a pilot project, so it's got a year's worth of funding, is how best we can engage communities in mutually respectful and equal partnerships to advance public health education. So it's about decolonizing that health education that's being provided, but also indigenizing that knowledge as well, to make sure that we are co-constructing with communities knowledge about health and health issues. Next slide, please. And yes, as I've already touched upon, the communities have often had little voice in these public health initiatives. There's often been a preaching from the top approach to delivering medical service, and everyday realities are not really taken into account. So by engaging with the communities, using participatory action research and ethnographic methods, working with the local medical schools, we're trying to build upon existing communities' knowledge and address the demarginalization of those communities. I would love to hear any suggestions that people have in regards to building partnerships and building equitable partnerships, particularly in academia and medical education, because those are things that are extremely challenging, particularly in the we have a lot of examples from Canada and the US, but in other places we have very few examples. So thank you very much, everyone. That's my time. Apologies, it was a little rushed.
Thank you so much for sharing.
All right, it looks like we lost Goodness for a moment. We'll just give her a moment to jump back on. Are you there, Goodness?
Thank you so much. Thank you, Laura, for sharing with us, and I hope that we have some more time to give room for the audience to interact. But very quickly, we would really love to hear the story of how Innocent Grants is doing an amazing work in shifting and sharing power in practice through his organization, the Young and Alive Initiative. Innocent Grants, please kindly share with us.
Thank you so much, Goodness, and again, good evening, good morning, good afternoon, everyone. As I introduce myself, I'm Innocent Grant, and I work with the Young and Alive Initiative, which is a local youth-led organization based in Tanzania, but also we're part of the IBP Network co-chair, where we work very close with Nandita at the World Health Organization. And I think one of the practical mechanism, maybe for power shifting, that I wanted to share today, as we thought is one of the strong partnership pathways, also building on the conversation that Nandita was sharing about trust. I think to us here and alive, what we learn is when the global partners trust local organizations, and when they trust in our abilities and capacities, we also could be foreigners in some of the communities within our own countries. So we also have to trickle this trust and power to the community themselves, in where where the actual people are coming from. So I'd love to speak, for instance, on the model we did this year. We're organizing a huge Young and Alive Summit in Tanzania, which we just concluded today, which brought together more than 250 delegates across Tanzania in this central Tanzania place called Dodoma. And the aim of this summit was sexual reproductive health outcomes among young people in Tanzania. But before we did that, we decided to go back to the communities. We designed this model, we call it the community dialogues. We went back to the communities and conducted a series of They met more than 975 people in their own communities to discuss about what are the issues coming from these communities, what are the priorities when it comes to sexual and reproductive health that are coming from these communities. And we didn't go there by ourselves. So I'll give an example. We divided Tanzania in terms of zones. So we had 6 zones in different across Tanzania. We called for application for young leaders to apply to be zonal coordinators, the summit zonal coordinators. We didn't consider whether they have a PhD or they have a master's or they have a bachelor degree in public health and sexual and reproductive health related work or in project management. But because we're just joining as zonal coordinators and maybe volunteers, because what we are compensating them is actually not enough. It's just an allowance to support the work that they are doing. We had 6 of them got selected with a mix. Some of them went to school, some of them didn't went to school, but these are people with a huge influence in their own local communities. They have an ability to identify issues going on within their own communities and actually being able to work with the communities to co-create on what works in Dodoma and what works in Mbeya and what works in Mwanza in different places of Tanzania. And then these are the people who ran the community dialogues across the country. And these community dialogues are actually supported by the IBP network. So it starts from there. It starts from the trust from the IBP network to Young and Alive. And then from us trickling it down to the community themselves. So we have this amount of budget. What can we do to support better sexual and reproductive health outcomes? So we designed a guide document which involved like a story for the zonal coordinators to use in gathering feedback. We had a lot of stuff coming from the communities themselves. And I think from there we learn trust is very necessary when we want to truly shift the power. So we trusted the zonal coordinators to run that. But also we came to learn acknowledging the power of the community themselves. Sometimes we partners working in civil society organizations or working donor organizations. We tend to think we are the only one who have the power to do transformation without acknowledging that even the community themselves actually have their own power of identifying issues going on within their own communities and being able to address them. So we worked with, so we have a problem of power sometimes goes back and forth. So they went and identified a number of issues, including issues related to strengthening comprehensive sexuality education, socioeconomic challenges for young people, creating more safer spaces in the communities for them to talk and identify issues, issues of strengthening health services for young people. These were issues coming. The role of men in promoting better reproductive health outcomes, issues related to mental health. We sat with these young people now to design how do we present these issues to the biggest summit in Dodoma. So we developed a very strong program that guided us the way we worked in Dodoma since Monday till today. So one thing I think I've learned over time is with such a great summit that we did, that I've learned doing stuff. When we don't do, we won't see the outcome. But when we start testing the ideas we have about shifting power, then it works, and we can actually start seeing the outcomes happening. So I would say that's one of the an example I wanted to share about one of the practical pathways we were.
Brilliant. This is really brilliant, and thank you so much for sharing with us, Innocent.
Coming near future weeks. So get prepared, everyone. Maybe I should end there, goodness, and give it back. And happy to chat more with anyone who is interested in this partnership work.
Yeah, thank you so much for sharing that with us. Thank you for sharing, Innocent. I hope everyone can still hear me. So far, we are glad to hear how, as individuals and leaders in civil society space or youth-led organizations, we hold power. And it's not only between the global south versus global north. The power we hold in the communities we share, how we trusting, how we listening, how we collaborating, how we meaningfully engaging, how we identifying these problems with the community, working with them to co-create the solution and giving them the agency to lead the change they want to see. Thank you for the amazing work you're doing. And with this, given the limited time we have, we would really love to get some engagement from our audience. So we have room for one person in the audience who is able to use 1 minute to share with us some of your biggest reflections from today's session. It could stem from the work you're doing or some of the barriers you have experienced when it comes to shifting and sharing power. Or at the same time, it could also be what you think could be the opportunities for us to shift and share power. So if there is anyone, please feel free to raise your hand and I'm just going to call you up immediately. If you want to share with us, I see a hand up already. Sita Shankar, I'm going to give you 1 minute. Miracle Ogba, I'm going to give you 1 minute. Please, I would appreciate to call you. Please, can you use the chat box to also type your reflection or whatever you want to share? The admin would unmute you, so please go ahead to share. Debbie or Brian, please just enable any of them to speak.
Hello.
Hi.
Hi.
Please go ahead. Thank you.
Good afternoon, good evening. This is Sita from India. A lot of the conversation today really resonated, and especially what Nandita said, because it was related to India. Yes, there's a I also put my comments in the question answer saying that, yes, there's a very, very top-down approach when donors come in with, we know it all. But since a lot has been said about these things, I wanted to talk about data and data usage. The kind of data we collect in our programs and the reports we write gets rewritten by top universities in America and Canada and published in their names with our names in as a tiny little footnote, which cannot even be seen with a microscope, I think, and that's something I think, I don't know whether I want to call it after effect of colonization or whatever, but that's something which is really not fair, because all the hard work is done by our communities and by us in our country, and just a few things are changed a little bit. Very academic modeling and frameworks are used, and the names are put in Lancet and in top publications. I think that is something which was not touched upon by most people here. But since there were so many academicians, I thought this was important to share. Thank you.
Thank you so much, Sita. Thank you. That's an important point to note in how decolonizing knowledge is important. Knowledge production, knowledge systemization, and knowledge use. And this is one key area we are glad you're able to highlight. Miracle, if you can use 1 minute, please go ahead to share your reflection or what ways you think we have the opportunities to bring the change for equitable partnership. more equity in sharing power and population health. Miracle, are you there? Brianne or Dabi, please, are you able to unmute her mic? Okay, please, if you have any other reflection and you are not, sorry, because of time, I can't hear you. Yeah, if you're not able to share that with us, we would appreciate. Okay, Miracle has typed out hers. Thank you so much, Miracle, for sharing your feedback with us. How do we overcome the problem of people management in running an organization and making impact? Thank you for that reflection. Why do we still have very low levels of compensation for community members time, even though we say that we acknowledge the fact that community knowledge and experiences is invaluable in shifting power? So these questions are very pertinent questions, and one very exciting part of what we do as the community of practice on shifting power in sexual reproductive health and rights is these conversations are ongoing, this dialogue are necessary, and it's built up into more rooms to explore these questions. Because of our time, we may not be able to deliberate further, but we have some sessions coming up in the coming weeks and months where we would be exploring some of these topics, and I want to encourage us to please stay connected to the community of practice. My colleague would be sharing a QR code which you can scan, or a link on how you can join the Shifting Power in SRHR community of practice. Another valuable thing about it is that the members of the community of practice, we often share useful resources that can support us to address these inequities that exist in engagement at the community level with philanthropic organization in knowledge production. So I want to encourage us to please join the community of practice, and we also hope that we will be able to reach back to our speakers to provide answers to some of the questions that you have raised that we have not been able to provide response to. In the Q&A section, I saw a question from someone who is from Sudan who was saying she would like to join a platform where she can get more support, or also amplify the issues that affect her community, and join hands together to solve this issue. And this is also another amazing platform to engage. Like I said, it's a community of practice, and you are more than welcome to always share, learn, and also foster partnerships. We also have a brief poll we would like to run, and this poll would also help us to get your reflection as audience on this call. We are sorry we are running a bit late, but we should wrap this session in the next 4 minutes. So please check the comment section to take the poll, and we would love to know ways you feel that you can get more support. The poll would be very helpful to work on some of the lapses and build more collaborations with existing organizations and bodies, that, and definitely collaboration. So please take some time while you're on this call to fill the poll to the best of your abilities or as you find necessary. Thank you to all who have been able to respond so far. I can see the response rates are increasing. We will stay on for the next 2 minutes as the poll goes. I also want to speak. I know that there's a question in the Q&A. I don't know if while the poll is running, if it's for, the question is for one of our speakers. Some of them have been answered, thankfully. Okay. Let me see if I'm able to answer. So for Dolly Sarah, I've already mentioned that please join the community of practice, and we are more than happy to provide that support you need in the work you're doing. I think those are the questions that needs response. Thank you. Thank you all for responding. We still have 2 more minutes to be on the call. While we are here, I want to encourage us again that you can always come back to listen to this session and maybe share with people in your organization or your institution on ways that you can actually localize the decolonizing maybe global health or power shifting concepts. In many spaces, we see that this word is sometimes becoming a cliche, but then we can see from the work our presenters are doing at the institutional level, at the organization level, through multi and bilateral collaboration with INGOs and local NGOs, that this is possible. In population health, equitable partnerships are possible. So I want to use this time to thank the amazing speakers who have shared their inspiring stories with us. Thank you so much, Nandita. Thank you, Innocent. Thank you, the Fair Network team, Amber, Sally, and Patrick. Thank you so much, Laura. I really appreciate the time you have given to this. We also want to thank the IAPHS team who have supported through their collaboration to host this webinar. The recording will be posted on the ICFP website. Stay connected, and we look forward to doing amazing things with you. Thank you. Sorry, table, we are out of time. This call will be ending in 1 minute. We may not be able to take your question. If you are able to send us a message through any of our social media platforms, we are happy to respond to you. Thank you. Thank you, Moses, for the feedback. Okay, so it seems that our host is able to give us some more minutes to talk. If you are still on the call table, maybe I give you a chance to speak because I can see your hand has been up for a while. Table, do you want to unmute your mic and speak? Okay. Brian or Nabi, please, can you please unmute Table's mic?
Hello. Greetings to all members of this webinar. My name is Debo Cynthia. I'm a midwife from Cameroon. I want to thank you all for the knowledge I've been enriched with. A lot of information on how we can shift power in our own area of work. My point of interest here and my worry is the fact that I work as a midwife in a local community here in my country. And presently, I was appointed to the post of a ward charge. So the difficulty I face is because when we give reports, despite the fact that we are trying to step down the rate of maternal mortality, when we send reports to the district, the reports we don't get the feedback or what we actually need to ameliorate on the field. So at my own level, I've been trying to go down to the community, especially after I attended a virtual conference of the International Conference of Family Planning. Been trying to go down to the community, talking to women in the community and encouraging them on aspects of their sexual reproductive health and the the reasons why they have to do it, because it's also one of the pillars of reducing maternal mortality. My interest at this level is also because I'm struggling to get papers to also be an activist for sexual reproductive health. And at this level, I've also been doing voluntarily my own services where I went down to the Pygmies women in the East region. I did them antenatal care, and those who were interested in family planning were orientated. And I was glad to have 2 women who opted for methods of contraceptions that they received. Thank you very much. My interest also at this level is because I studied as a midwife, and because of lack of funding, I have not been able to progress with my education. And I think that I'm interested in doing a master's in public health and something related to maternal health, so that, because most opportunities I see at the level of development, at the level of policy making in my country, they are limited to people who have a particular level of study. So I think that if I have the opportunity to do a master's in public health related to my domain, I will finally get to the level of decision making, and most of the things I'm presently studying, I'll be able to put them in practice. Thank you very much. Thank you.
Thank you so much for sharing, Table. We hear you. The work you are doing is phenomenal. It is making a difference. And we also can understand some of the struggles you're experiencing. What I would say is that you can shoot us an email, and then we would see ways that we can gather some support within our network in terms of capacity strengthening. Like I said, the community of practice is made up of individuals and institutions from different countries and doing amazing work in different frontiers. So there will be relevant resources that can support you in some way, or we can point you to resources that can be helpful. So you can point or get in touch with some of us. We are happy to support. And again, amazing work you're doing in your space. Unfortunately, we are unable to take more feedback, but thank you. I hope you imputed some of those in the poll which we ran, and also you're able to stay connected. Thank you, everyone, and have a great day. Thank you for joining.